Dear all colleagues, member, we will begin this section, Advanced IOL Power Calculation. The first speaker is Cai Junbin. Cai Junbin is Associate Director of Tainan Qingming Eye Clinic. He is training at the Veteran General Hospital, Taipei. Let's welcome Cai Junbin 医师。
Good morning, ladies and gentlemen. I am Thomas Chumpin Cai. It's my honor to be here. Today's my topic is tips of idle selection and calculation for patients receiving RK. It's my financial disclosure. We all know that RK was introduced in 1974 by a Russian doctor. Nearly 1.2 million people underwent RK surgery between 1980 and 1990. Nearly 80 to 90% of the cornea thickness was cut. That's a 3 to 4 millimeter central optic zone. Multiple radial cuts are applied based on a nomogram to correct mild to moderate myopia. RK is a form of planned keratoectasia. This deepens the peripheral cornea, which in turn flattens the central cornea. The problem is that over time, the progress hyperopia shift may continue, and we have to consult patients that no matter what we do today, these RK incisions could continue to change, as will their vision. If they don't understand this, you could have a very unhappy patient. According to the prospective evaluation of radiokeratomy study, between 6 months and 10 years, the refractive error of 43% of changes in the hyperopic direction by more than 1 diopter. The average hyperopic change is 0.06 diopter per year between 10 and 10 years. So the refractive error in the continue during the entire 10 years after surgery. Smaller optic zone show more hyperopic change than eyes with larger optic zone. In addition to the hyperopic drift, RK eyes refraction may also fluctuate throughout the day, making the intended refractive goal a moving target. To the fact that a significant proportion of RK eyes are more hyopic, especially in the morning, this diurnal fluctuation is due to hypoxic edema and intraocular pressure change. This 59-year-old male patient, he had taken 8 incisions RK surgery 30 years ago. He complained blurred vision in the morning. There is a flat K in the morning, which results in hyperopia at sunrise. If there is enough space, I would put my cataract incision between the RK incisions. This is possible with 8 incisions RK. But with a 16 incisions RK, I need to go back to make a scleral tunnel. It is wise to watch the RK incisions and the zonules carefully during the procedure. This incision can sometimes open during the surgery, causing micro or macro perforation. So you must be prepared to close them with sutures if it is happen. Unlike LASIK, PRK, or SMILE, RK flatten the anterior and posterior corneal surface, but only in a small central optic zone. The effective optic zone can be significantly smaller than the measured zone of standard keratometry. Many keratometers measure at knee of treatment zone. Therefore, standard keratometry tend to overestimate the true corneal power. This increasing the risk of hyperopic surprise. As I mentioned before, RK eyes is an unstable cornea. Diurnal fluctuation could happen. It is wise to choose a flat K in the morning. Idle power calculation following RK should not be carried out using 2 variable third generation theoretical formula, such as RKT Holiday 1 or Hofer Q, because these idle formulas assume a relation between keratometry and effective position. RK eyes are once myopic, but now have flat cornea. They typically have a deeper anterior chamber depth than patients with similar flat K reading who don't have a history of myopic refractive surgery. Therefore, more advanced formula may be more accurate for RK patients. For example, the Haggis, Holiday 2, and Berry Universal 2, and now it's Berry 2K, can take into consideration of the anterior chamber depth and determine the final effective prediction. Using the average output from the ASCRS calculator, rather than favoring one formula, is a popular option with some surgeons. But taking the average of multiple formula will dilute the overall performance of more accurate method. The ASCRS average output has improved as more advanced formula has been added to the calculator, but it will always be limited by the less precise method. So I prefer not to do this approach. According to the study published in 2020, if you have the refractive record before RK surgery, you can use Berry 2K formula with history of RK. Nearly 74% of the patients' refractive result will inhabit diopter. If you just have the post-RK refractive result, you can use the most hyperopic refraction record for the patient. This was to allow for the progressive hyperopic drift that occur after RK, but also to control for any myopic shift caused by nuclear sclerosis. This partial history option was released in 2K formula of RK 5 years ago. The partial history option can fine-tune the refractive outcome of RK eyes. If you don't have any refractive history of the patient, you can use Haggis formula or Berry 2K formula with no history of RK. Almost 70% of the patient refractive result will inhabit diopter. Many surgeons to select a refractive target of between -0.5 and -0.75, even -1 diopter for two reasons. First, hyperopic errors are common, and second, if hyperopic shift continue, the refractive error will change toward ametropia. How about aura? It may be considered post-LASIK, PRK, or SMILE, but don't use in post-RK eyes. Why? Because intraoperative aberrometry is sensitive to IOP during capture, but there is microleakage in RK eyes. Multiple RK cuts encroaching the visual axis make an inaccurate measurement. Measurement can be affected by intraoperative corneal edema and corneal instability. In a spherical IOL with negative spherical aberration, is suggested because it can offset the market elevated value of anterior corneal spherical aberration in RK eyes. Most eyes with astigmatism post-RK have some component of irregular astigmatism. Benefit of reduction of astigmatism with toric IOL has been reported in eyes with irregular astigmatism due to keratoconus and corneal transplants. Reduction of high amount of refractive astigmatism is benefit to patient. Toric IOL implantation is a safe and effective tool for reducing refractive astigmatism following cataract surgery in post-RK eyes. Toric IOL can be considered in this situation. First, no contact lens were anticipated. Second, spectacles with astigmatism correction pre-cataract give good vision. Third, topography shows stable regular astigmatism in central millimeter. There are three criteria. Criteria 1, regular bow-tie astigmatism within central 3 millimeter zone. Criteria 2, difference in corneal astigmatism magnitude between different optometry is less than 0.75 diopter. Criteria 3, difference in astigmatism meridian between different optometry is less than 15 degrees. This 50-year-old female patient had received 16 incisions RK 30 years ago. Her astigmatism magnitude between aeromaster and lens star is less than 0.75 diopter, and the meridian between different optic biometry is just 4 degrees. This is her eye trace data. She has both regular and irregular astigmatism, although her bow tie pattern shows irregular and asymmetry. But her estimated sleep axis agree with Idolmaster and then start. So this patient get better visual acuity with glasses to correct her astigmatism. So we can suggest the patient to have a toric idol implantation to correct her low order aberration. There are residual high aberration for this patient, like coma, trefoil, tetrafoil, and spherical aberration. So this patient may have some positive dysphobia, like halo, starburst after cataract surgery. The hydro-operation bars help out to set realistic expectation for the patient. Just as Dr. Halliday said, RKIs has multifocal cornea. You can see RKIs have a wide range of focus. It is up to 13 diopter. This kind of multifocal cornea is in center that is relatively flat for distance and peripheral that is relatively steep for near vision. Following RK, the overall lack of precision of IOL power calculation, a dynamic fluctuation in refractive power, and increase in high-order aberration preclude use of traditional multifocal IOL. High-end multifocal IOL with many diffractive ring adds to already multifocal cornea. It will further reduce contrast sensitivity and increase symptoms of halo and glare. Low-end multifocal IOL or EDOF IOL are more forgiving in some RKIs. It is case by case. Just for incision is a good candidate. More than 8 incisions, like 16 cuts, must be considered. If you have a larger optic zone where the normal pupil size is a good candidate, we must always remember the more cuts you have, the more high-order aberration you have. Of course, no obvious diurnal fluctuation in K. That means it is a relatively stable cornea, and prepare to perform IOL exchange if the result is not satisfied. This patient had 8 incision RK 30 years ago. His optic zone is about 3 millimeters. There is no obvious high-order aberration noted. His vision was great after RK, but before the cataract reform. He's a good candidate for multifocal IOL. Don't panic or celebrate on the first day post-operatively. There can be central cornea flattening after the cataract surgery due to RK incision softening by using steroid frequently. Most of the flattening effect resolve after 3 months. We can see this patient's refractive change. First, this is mild hyperopia, then a high hyperopia, and finally result in a mild myopia. RKIs is an unstable cornea. In short term, there is diurnal fluctuation. We need to select the refractive K. In long term, hyperopia progression year by year. So, intentionally targeting myopia is safe. Use ACD-related IOL formula like Haggis or Berry 2K formula with or without RK refractive history and choose the highest IOL power obtained. A spherical IOL and toric IOL is suitable in RKIs. Multifocal IOL is a challenge in RKIs. Low-end multifocal IOL or EDOF IOL may be a choice in fewer incision RKIs. These eyes have less high-order aberration, larger optic zone, no obvious diurnal fluctuation in K reading. Patients must understand the potential for a refractive surprise, under promise and over deliver. Thank you for your attention.